So it's really good to know, things happen, maybe in the long run for the good. So Professor George Hollander is actually is a Hoffman and Action Medical Research Professor of Developmental Medicine, and he's the head of Department of Paediatrics in Oxford University. Can I call upon you, George, to just say a few words to open this webinar? Thank you.
Well, thank you very much. Good morning, everyone, at least good morning here from the UK. Good late afternoon in Malaysia. We are in clearly unprecedented times. Global threat, we had to adapt almost every aspect of our daily lives to the pandemic. These are probably the more threatening and unpleasant sides. But from a medical point of view, I would also say that science has gained respectability and value in that time. And it is the science that allows us to be rational about the fight against the pandemic. And rational in this case also means the exchange of information. And this is exactly what we do this morning. And so it's a great pleasure to start this mini-series of talks with my colleague Matthew Snape, who's going to talk about COVID-19. And it's a pleasure to have you all on this webinar, and I look forward to many more of those.
Okay, thank you, George. Yes, I also want to add to say that this webinar was actually planned as kind of events towards celebrating the soon to be opened new children's hospital for the Universiti Kebangsaan Malaysia, and the intention was to get people together to so-called celebrate the opening. Unfortunately, this pandemic has actually retarded the process. But nevertheless, this is still a very important platform to convey very pressing issues, like George has rightly pointed out. It's unprecedented times, as well as having to grapple with this difficult time with pandemic with COVID-19. So yes, the most important thing now is to introduce our speaker. Before that, actually, sorry, the moderator is Dr. Adli Ali, who is a faculty member, who's a department member, who just come back from Oxford. And Professor Hollander is actually his supervisor. So hopefully by the end of this year, Dr. Adli will gain his PhD from Oxford. So Dr. Adli will moderate the session later on with a Q&A. So for those people who have questions, please type into the Q&A, and Dr. Adli will sift them out and try to answer those questions with our speaker, who is none other than Associate Professor Matthew Snape. And Associate Professor Matthew Snape is the Associate Professor in Paediatrics and Vaccinology. He is a key person in the Oxford Vaccine Group. And his principal areas of research has been in the vaccines against meningococcal, pneumococcal, influenza, and as well as RSV. But in this 1 year, he is the chief investigator of what's the story, in evaluating the rates of COVID-19 infections in children. So without further ado, I would welcome and please call upon Associate Professor Matthew Snape to actually deliver his story on COVID-19. Professor Snape, please.
Thank you very much. Thank you very much, Professor Cherry. I needed to be unmuted there. Thank you. Good. Thank you very much for this invitation, the opportunity to talk to Kuala Lumpur. I was saying to my colleagues over the other side of the world, I was saying that I've been in Kuala Lumpur only once, about 30 years ago now, which is a shamefully long time. I would love to get back there. I'm going to share my screen now so that we can look at these slides. So just bear with me while we do this. And I'll now go to, can you see this? And I'll now go to the speaker view. And I'm hoping that you can see that okay. Is that right? Full view?
Yes.
Wonderful. Yeah. Okay, wonderful. So I'm talking about, I'm a pediatrician, and so we're talking today about children and COVID-19, looking at their susceptibility to infection and their transmission, and the relevant areas, and potentially, and in the end, talking about the indirect effects of children. Some have recently authored a perspective in science where we've really been discussing the indirect effects that children have borne during this pandemic, which I think they have borne disproportionately. And so we can come on to some of those issues at the end. Just to give some context at the start, this is from our World in Data, looking at the number of positive cases for COVID-19 per million people in the UK and Malaysia. And obviously this is very influenced by the number of tests being done. So although it looks like in the second wave there have been many more cases in the UK than in the first wave, this probably reflects a large number of tests being done. To what extent that is also the case in Malaysia, whether this is a real difference or an apparent difference, I'm not the one to say. Although when you look at the deaths per million people, confirmed COVID deaths, you can see that in the UK we have had a hard time of it. In excess of over 50,000 excess deaths in the UK since the beginning of the pandemic, and we are on the upward slope once again, unfortunately, in our second wave. And I'm very glad to see that, at least according to these data, Malaysia seemed to have been spared this, so you may be able to offer me some perspective on that. Looking at the timings of this, to give some context to what we're going to be talking about, we had this first wave in March onwards, and the country went into a national lockdown in late March, and that included the shutting of all schools in late March. The shutting of schools was associated with also, my apologies, I think I may have, there we are. Sorry, I've just had a bit of a trouble here. There we go. Now you can see my laser pointer. The shutting of schools occurred in late March, associated with shutting of all restaurants, pubs, etc. These reopened in May, and we had this reduction in cases and relatively few cases and deaths during the Northern Hemisphere summer. And then a lot of things happened in September at the same time. Schools reopened. People came back from summer holidays and travelling in the continent, some of which were to countries of reasonably high risk. And pubs and restaurants reopened. And now, perhaps inevitably, we have gone into a second lockdown where schools have remained open in the UK, but pubs and restaurants and non-essential businesses have shut, and people have been, again, encouraged to work from home. The focus on working from home has actually remained through the whole study, through the whole period. So that gives some context, but we're now specifically talking about COVID in children and looking firstly at the disease rates in children. And it won't be a surprise to anyone on the call that there's been relatively little disease in children. Here's one of many publications that have addressed this. This is looking at the number of children admitted in England with COVID-19 disease during the first pandemic peak. And you can see that in the yellow dots, that is 50, yellow corresponds to 50 or so children. This is in different regions in England. And overall, the message is there were very few compared to the numbers we were seeing in adults. And whereas in adults, we saw an enormous spike in excess all-cause mortality during the first wave, in children, if anything, we saw a reduction in mortality. This is the green line that we can see here is actually observed number of deaths. And then the black line is when this has been corrected for other factors, but simply no increase in deaths in children during the first wave of the pandemic, which of course is great news. The pandemic has been bad enough. I think everyone would hate to think what it would have been like if children were being affected as much as the older population have been. We also know that during the first wave, if you did a test on a child looking for the SARS-CoV-2 virus, you're much less likely to find that virus in children than you were in older age groups. So this is all age groups of children, and then this is your adult population that you can see here. So less than 10% of swabs taken, and this is for children with an illness, a respiratory illness, less than 10% were positive. And in fact, it was not possible to tell who had SARS-CoV-2 from their presentation. If a child presented, and this is American data now, with congestion or runny nose, or a headache or sore throat or cough or even fever, you could not predict if the child was going to be SARS-CoV positive or negative. It presented like any other respiratory illness, with the exception of like loss of smell, as we know is quite a predominant feature. We'll come back to these data in just a minute. So do the relatively low numbers of acute COVID-19 in children reflect, is it a resistance to infection or a resistance to disease? And initially we were thinking possibly they just actually weren't getting infected. And some of the data that suggested this came from contact tracing studies, where once there was a known case of COVID-19, these studies all looked at testing the contacts around them and found that children were much less likely to be positive than adults when you did contact tracing. However, at least some of these were biased by sampling, so that only those with symptoms were sampled, so they wouldn't be picking up asymptomatic infection. And perhaps a more systematic approach to doing this is with population-based surveillance, which can pick up not just disease, but also asymptomatic infections, regardless of known exposure. And here they're telling a very different story, especially now, we're now onto the second wave of illness. So these are of disease in the UK. These are data from the the Office of National Statistics in Survey, where they're doing a population-based study, sending out swabs to be taken by the participant themselves and then sent back for testing, with many thousands being done every week. And these are finding that actually the positivity rates in children and young adults are as high, if not higher, than older population. So in the top left here, we have what we'd call primary school age 2 years to about 12 years of age, and then 12 years to around 16 years of age, 17, and then around 17 to 24 years of age. So you can see the highest rates of infection, and this is what we're looking at here in in year 12 to 24-year-olds, so that's something like 17-year-olds to 24-year-olds. Around 2%, 1 in 50, are positive at that time of testing. And that is higher, if anything, than in the middle-aged population or the elderly. So, and that also is being seen around 1 in 100 in 2 to 12-year-olds, and up to 1 in 50 again in around 12 to 17-year-olds. So children and teenagers are being infected, but they're not getting sick with it. Another way of looking at this is through seroprevalence, looking for antibodies. This is a study that we've been running, which actually started life as a vaccine seroprevalence study and then was repurposed to be a COVID-19 seroprevalence study. This is looking at healthy active serum collection from healthy 0 to 24-year-olds in 10 sites across England. And we've now recruited over 1,700 participants, with the results presented here from the first 1,000 or thereabouts, but recruitment is ongoing. This is being done in collaboration with Public Health England. And here we're looking for antibodies against both the nucleocapsid protein and also the receptor binding domain element of the spike protein. And I'll be just showing results for the nucleocapsid protein results today, which is being performed on the Abbott assay. The manufacturer has a threshold of positivity for this of greater than 1.4. However, when Public Health England subsequently did their own analysis, they actually used a cutoff of 0.8 or above as positive, which is what we're seeing here. So in the results that we had through the before and then during and immediately after the first wave of illness in the United Kingdom, we were seeing that prior to the infection, as expected, there was only 1 out of 120 participants that were positive. That was one case in February, which may well have been a false positive But by April and May, 3.7% of our 0 to 19-year-olds had antibodies against SARS-CoV-2, and that had increased to in June, July to 5.1%. And if you correct for the sensitivity and specificity of the assay, this gives a corrected seroprevalence of around 2.9 to 4.4% in these two different periods. So we're seeing infections again in around 1 in 20 children, between 1 in 20, 1 in 25, 0 to 19-year-olds by June, July. It had shown infection during the first wave. There did seem to be an increment with age, so by June and July, we're seeing easily the highest rates of antibodies in 20 to 24-year-olds. So that's around 16% positive there, falling to around 6% in 5 to 19-year-olds, and then lower still in the younger age groups, albeit with wide confidence intervals that we have to acknowledge. Numerically, there was some variation by geography, and as was seen in the first wave in adults, highest rates of infections were being seen in London, and the red circles here represent the number of positive cases, and the blue circles the number of swabs taken to give an idea of the sample size. The main thing is that we're seeing around 11.7% positive in April and May in London, which was far higher than the rest of the country numerically, and by June, July, still high, although with a relatively small sample size there in London, and we were starting to see an increase in the rest of the country. So Bristol had gone up from 0.4% to 7.9%, for example, Manchester 5% being positive here. So this did reflect what was being seen in adults, the distribution that was being seen. We then looked to do more formal statistical analysis to see if this stood up when it was looking at univariate and then multivariable analyses. And actually, the age trend that we saw didn't come through so clearly when corrected for other factors. Perhaps this may have been a powering issue. And similarly, actually, even for region, whereas numerically it was much higher in London than other areas, perhaps didn't come through as being statistically significant. That may have been a powering issue. But what we did see quite strongly was an association with ethnicity, and that there were higher rates on the Abbott assay, the results we've been looking for, nearly 3 times as likely to be seropositive if participants were from a black and minority ethnic background compared to a white background. And in the UK context, black and minority ethnic means usually from an Afro-Caribbean or Asian population. And we are now focusing recruitment on this cohort so that we can get more granularity about if there is any difference amongst those populations compared to a white population in the UK. So there was around 2.9.3 times higher for black and minority ethnic. The other finding, other striking feature, was that there was an association between antibody positive and increased wealth. So this was not a function of necessarily household crowding or lower socioeconomic conditions, that actually the wealthier cohort were more likely to be seropositive. And so these are independently associated. Being black and minority ethnic is independently associated with being positive, as is having increased wealth. And this association with increased wealth in particular has been seen in the swabbing studies, where the least deprived quintile, by the time you get into September, were most likely to be positive. This may reflect travel patterns and holiday patterns over the summer holidays. Amongst our 0 to 19-year-olds who had antibodies, the vast majority had had no symptoms whatsoever. We asked participants if they'd had any flu-like illness from February up until the time of blood sampling. And as you can see, amongst the dark blue is asymptomatic, light blue any symptoms, and this obviously could have been an intercurrent viral illness, non-COVID. But the vast majority had no flu-like symptoms at all, even if they were antibody positive. That is less so in the 20 to 24-year-olds in our sample here. So we can say that contact tracing initially seemed to show lower susceptibility to infection than adults, but in contrast, population-based swabbing and seroepidemiology studies show similar rates of infection between teenagers and adults, children, teenagers and adults. We're seeing infection in children being associated with being of black minority ethnic background and increased wealth. And most pediatric infections are asymptomatic. But the key question is, do asymptomatically infected children transmit infections? And there was a lot of attention paid to this, and these are data from symptomatic children published by Yonkredal, which got a lot of publicity at the time they came out, because they seemed to show that children, it was reported as showing that children shed virus as much, if not more, than adults. And I'm not completely sure that the data actually, that conclusion holds up. What we see here is, firstly, the thing is that these were symptomatic children. These were children that were admitted to hospital or seeking acute care. So it's not the asymptomatic ones out in the community. And as we've already shown, there are very few symptomatic children with COVID-19, in hospital especially. So they're an unusual group to start with. And then when you actually look at the comparisons that were being made, and this was the one that got all the attention, comparing viral shedding in children, in the red here, with adults, and showing a statistically significant difference. But this was actually, children were predominantly done in the first 2 days of the illness, whereas the comparisons were being made with children who, with adults who are at least 1 week or up to 4 weeks post presentation. So really not valid comparisons, I think it's fair to say. And I don't think we can say one way or the other about the impact that children might have on transmission from this. What's much more relevant is the large numbers of asymptomatic or mildly unwell children and whether they are spreading infection. And we've already seen that children do get infected, but that does not necessarily mean they're transmitting. And what do we know about transmission? So here, this is similar data, again, the swabbing data, which is looking at what happened around the time of the reopening of schools. And you can certainly see that schools were reopened somewhere between the 1st of September and 9th of September. And in school, this is secondary school and primary school, we do see an increase in infections around this time. And then in late school years and young adult years as well. And many have taken this to show that this shows that schools do spread infections, or are focused for spreading infections. And that may be the case, or it may not be. I don't think we can say from this, because many other things were happening around this time. Businesses were reopening. People were going back into work a lot more. People had come back from summer holidays. So there's a lot of general circulation in the community around this time. And it can equally be that this is just representing what's happening in the broader community. And it is interesting to note that looking at the infection rates amongst teachers, that their infection rates are no higher than other professions in England. So this is nursery, so very early age teachers, primary school, so 4 to 12-year-olds, teachers of 4 to 12-year-olds, teachers of 12 to 17-year-olds, with no higher rates of positivity than other professions, which is, I think, interesting and worth bearing in mind when looking at whether schools may be responsible for transmission. The other way to look at this is to look at where there is an outbreak within a family and who brought the infection into the household. We're all very familiar with other respiratory infections or gastrointestinal infections, that often it's the young child that brings it in from nursery and then their parents get unwell with it. This does not seem to have been the case for COVID so much. These data are slightly old now, and actually they do have their limitations, and they're mostly looking at who got symptoms first in a household, and as we've already shown, children may not have symptoms. But even from this, they showed that only around 8%, so 3 out of the 39 households they were studying, did a child develop any symptoms prior to any household contact. Looking at schools again, if you want to look at schools and whether the schools are driving transmission through the broader community, it's helpful to look at countries where there is a low incidence overall, and you're not having multiple introductions into the schools from the community, but only a single introduction into the school from the community. And here, Australia, I'm Australian originally, and Australia, as many will be aware, has had very low rates of disease. They've done some really extensive contact tracing within schools. And so here we have data from New South Wales, where there are 863 students or teachers exposed to 18 index cases, 9 of whom were students, 9 of whom were teachers. And from those 863 exposures, there are only 2 secondary cases, one in a student, one in a teacher. And this was across both primary schools and secondary schools in New South Wales. So you can see that all the green cases here, so in these figures here, we're seeing the cases themselves. This is in secondary schools, 1 secondary infected student, and all the other students here were uninfected and the teachers uninfected. So that suggests that if schools are isolated, then students are isolated, and the students were taken out once they were positive, that there is little onward transmission. But outbreaks in schools have occurred. For example, in Israel, schools reopened in mid-May, following which there was an extreme heat wave in Israel. And then there was a major outbreak of coronavirus in the high school, where around 13% of students became positive and 16% of teachers were found to be positive. Specific situations in this case was that it was quite a crowded classrooms, 35 to 38 students per class with only around a metre squared around each student. And it was extremely hot, so air conditioning was working over full all the time, and students were not wearing masks. And you can just see that actually, if anything, the infection rates were higher in the first few years of secondary school, 7th, 8th, 9th grade, rather than subsequent years. So, and there was a lot of extra classroom mixing with extracurricular activities such as sports teams and dance classes. So there does need to be some caution with the schools reopening to try and minimise spread. Anyway, what we can say from what I've just shown you now is that in the UK, school-aged children have virus detectable at the same rates or higher than adults. But the evidence that the children and schools are the drivers of transmission is limited, although the potential for school-based outbreaks does exist, so it's reasonable to take precautions. So just moving now on to thinking about why children don't tend to get sick with COVID-19. What's going on here, which of course has been an area of much speculation. And one thing is, firstly, to say is they may get sick, but not in quite the same way as we expect with adults. So it does depend what questions you're asking and how you're looking for it. And so if you're just looking for respiratory symptoms, we know that the respiratory symptoms don't look that much different from any other viral illness. But what they do see, and this is from a UK study, Swan et al. In BMJ, is that, and this is looking for constellations of symptoms and what do the children who ended up in hospital look like. And they did see some children with symptoms, a constellation of cough, fever, shortness of breath, or clustering together, but also quite a lot of abdominal symptoms. And I think this has been observed in different contexts around the world. Abdominal pain, diarrhea, and fatigue being just as much of a feature in children with COVID-19. And other seroprevalence studies have shown this as well, that children that were seropositive actually had more gastrointestinal symptoms than children who were seronegative, and the gastrointestinal symptoms were a much better predictor of seropositivity than respiratory symptoms. So that's worth bearing that in mind, that sometimes children might get sick and we might not be picking it up because we're not asking the right questions. So one question is then, why is there a relative lack of respiratory symptoms in children? And much speculation has been focused on whether it's because they have reduced expression of the ACE2 receptor, the binding protein for the spike protein, the binding receptor for the spike protein. Do they have reduced expression of ACE2 in their upper airway? And there is some evidence to support this. This is from the Yonker et al. Study in America, where they took the samples from the respiratory epithelium of children. And yes, they confirmed that these graphs that we're seeing down here show us that there is reduced ACE2 expression in children, younger children. They've cut the data 2 ways here. One is just looking at a binary outcome, under 10 years or over 10 years, and they found that was statistically significant, that under 10-year-olds had lower ACE2 receptors. And also when looking at a gradient across all the ages, a continuous variable. And they found that if you were SARS-CoV-2 negative, you had lower ACE2 expression than if you were SARS-CoV-2 positive. So these are the red is SARS-CoV-2 positive and green is SARS-CoV-2 negative. So there is some association there between ACE2 expression in the upper airways and being positive for COVID. But actually, there was no association between the viral load. So perhaps once you get in, one way of looking at these data is to suggest that once you're infected, then the amount of ACE2 that you have, once the infection takes hold, the number of ACE2 receptors don't matter. One of the other possible causes for the lack of respiratory symptoms or lack of illness in children is cross-protection from seasonal coronaviruses. And this area of a lot of speculation at the moment and interest. And one of the reasons people are interested in this is data from adults, and there's a whole series of papers looking at similar features here, showing that unexposed adults, and these are samples that were taken before the SARS-CoV-2 pandemic, the COVID-19 pandemic, that around 50% of unexposed adults had CD4 cells that were cross-reactive with SARS-CoV-2, and 20% CD8 cells that were cross-reactive with SARS-CoV-2, with either spike protein or the matrix nucleocapsid. So these obviously had not been exposed to SARS-CoV-2, and the suggestion was they'd gained protection from cross-reactive epitopes with seasonal coronaviruses. And there is a number of papers that have looked at this in adults and shown cross-reactivity with seasonal coronaviruses, however, none as yet in children, and that's an area that we're working on at the moment. But there's a really nice paper that's come out more recently from Scotland, which does lend some support to this. And whereas usually with respiratory infections, as I've repeatedly been saying, we would be worried about picking up infections from children, this suggests that actually living with young children is protective for COVID-19. This is looking at household contacts of healthcare workers. So it's taking healthcare workers in Scotland and looking at the number of children in their house. And this is correcting for age and occupational and part-time working, etc., etc. And this is looking at the risk of hospitalization here. So the purple, these are all risks of hospitalization over time, and looking at the date of the first positive test for those that were hospitalized. So if you have no children in your household, this is the purple line. If you have one child is the blue line, 2 children or 3 and above are the green and yellow lines respectively. And you can see that once you get into 2 or 3 children under the age of 12, you are much less likely to be admitted to hospital with COVID-19. And this stands up after correcting for age and socioeconomic factors, etc., etc. And also applies to any infection, not just hospitalization, but any infection. So this is now looking at the risks and hazard ratios for any COVID-19 for adults living in healthcare worker households by the number of young children in their household. So if you have no children under, that's your standard, and these models correct for the various features such as we talked about, age, socioeconomic background, ethnicity, etc., etc. Various model is increasingly correcting for those different aspects. And so if you have one child so if you have no children, then your risk here is 1, shall we say nominally. As soon as you have one child under 11 years age in the house, your risk is lower at 0.85 and then down to 0.77. And so overall, per child, there's 0.89 risk ratio for developing COVID-19, any infection, and that is statistically significant. That's a preprint, it's not peer-reviewed yet, but I think it's a really interesting suggestion that actually all we can say from this is that somehow children may be protective against COVID-19, and then the authors go on to speculate that that could be due to recurrent exposure to seasonal coronaviruses. So I thought quite a nice study looking at that. So these are the two. There'll be maybe other reasons. These are at least 2 possible reasons that have been looked at as to why children may be relatively spared coronavirus disease. So just to finish up with now, looking at, briefly really, at this syndrome called PIMS-TS or MIC, depending which side of the Atlantic you're on, or sometimes known as Kawasaki-like illness that was seen towards the end of the first wave in children and adolescents in particular in the United Kingdom. This is the case definition that's been put out by the Royal College, which is very broad actually. And my experience of being on call during this period of time was that we had 4 children on the ward that looked like they might have PIMS-TS. One ended up having glandular fever, one had juvenile idiopathic arthritis, one had something we don't know, and one was a standard PUO that resolved and was COVID negative on seropositive and serotesting. So this looks like many other conditions, but there is a real new illness that does seem to be specific for COVID-19. And this is from Swan et al. Again, looking at the numbers of their admissions for children that were being admitted to hospital with COVID-19, or in the UK calling MISC, multi-inflammatory syndrome related to COVID. And you can see the yellow cases kind of coming to after the peak of the first wave for infections themselves. And this is the American data showing that really fever, predominant persistent fever, is what makes this stand out from other COVID infections, associated sometimes with a cough, fever, rash, nausea, vomiting, and diarrhea. So fever and gastrointestinal infections symptoms as what stands out. Another paper again, Whitaker et al. This time, a UK case series, looking at analysing this case series of MISC cases compared with Kawasaki disease, or Kawasaki disease with shock, or toxic shock syndrome, to help clinicians try and make distinctions between these overlapping conditions that might have an overlapping presentation. And their main findings were that children with PIMS-TS were older than those with Kawasaki's or toxic shock syndrome, that they didn't have the high platelet counts seen in Kawasaki's disease, they were lymphopenic, and that's quite a striking feature. They had very high C-reactive proteins. They had a very high ferritin, over 1,000 usually, and troponin and D-dimer, features that just weren't seen in Kawasaki disease. So quite useful, and whereas albumin tend to be a bit lower than those in Kawasaki disease. So these are the tests that have become used as trying to distinguish between, if you do have a child with fever, abdominal symptoms, with COVID going on in the community, looking at the troponin, D-dimer, ferritin, and lymphopenia, and a lack of a high platelet count. In terms of the, we have jumped a slide here. I'm going to jump ahead here for 1 second, sorry. So look, in terms of who was actually getting sick with this, they tend to be teenagers often. So this is looking at risk factors, statistically significant compared to 15, 19-year-olds, 10 to 14-year-olds often presenting, and again, higher incidence from being Black and Asian populations, so 3.6 times higher for people from a Black ethnicity or South Asian compared to white. What's the other features that have been found with this is that compared with looking at different severity of illness, those with just mild syndrome compared to severe syndrome, this is from the American data, you see higher SARS-CoV-2 specific IgM, that's perhaps not surprising. You also see higher IgG against seasonal coronaviruses and influenza. And this suggests, so this higher antibodies against unrelated infections suggests that there may be a T and B cell overreactivity or autoantibodies that might be driving this inflammatory process. And even for RSV, seeing higher antibody levels, here's some violin plots looking at IgG against, and this is different categories that we have here. So these are children presenting acutely or acute adults. And here we've got mild multi-inflammatory syndrome versus severe multi-inflammatory syndrome and convalescent antibodies. This is looking at antibodies against receptor binding domain and nuclear capsid protein. Nothing too exciting there. These in the seasonal coronaviruses, and seeing higher antibodies against the seasonal coronaviruses in the red group with severe MISC, and against RSV and against influenza. So some kind of overactive immune response, raising antibody against multiple different antigens. Okay, so we will start to draw up here. Infection rates, similar infection rates to children. Most children are asymptomatic. Evidence of spreading in schools, I think, is still inconclusive, but needs to be carefully monitored. And there is some emerging evidence regarding the role of cross-protection against seasonal coronaviruses. And this PIMS-TS, this post-infective multi-inflammatory syndrome, is real, but it is rare, fortunately, and rarely fatal. And there are studies going on in the UK, I should have mentioned, where these children are now being randomised to either get methylprednisolone or IVIG. And just to change tack at the end, we know that children have been massively affected by coronaviruses, if not directly, but indirectly through all the measures that have been applied in shutting down of schools. We've seen an increase in non-accidental injury by children being locked up in households and being not visible to the broader community. And I think we need to bear in mind these things. This is looking at measles deaths. Measles deaths were already going up from 2018 to 2019 globally, and I'm worried, and I think many paediatricians are worried about what's going to happen during 2020 with measles deaths and other vaccine preventable illnesses with disruptions to immunisation schedules. I think children have suffered massively from indirect effects of lockdown, and I'm very pleased to see that every effort is being made in the UK, for example, to keep schools open, even during the second lockdown. I think society is rightly prioritising the needs and health of children and finding ways of making this work, keeping schools open, even while other measures being taken to control the outbreak. So, very happy to take any questions that you may have at that point. Thank you very much.
First of all, thank you very much to Professor Dr. Matthew for sharing the information. So I would like to move on to the Q&A session. So I may allow some verbal question and feedback from the floor. If you're interested to do so, please kind of like clap your hands, should kind of raise your hand, so I could basically invite you forward to pose your question. And additionally, we will also invite any comments or any questions. So please, if you are not keen or quite shy to ask verbally, you can basically post your question in the Q&A chat session. So I will possibly read the question and hopefully Professor Matthew could answer the question that is given. So just to start with, I mean, you did mention about anosmia and hypoxemia as one of the features, one of the clinical characteristics that differ between the common URTI symptoms and the patients who are affected with SARS-CoV-2 infections. I think the main question is that how is this can be applied in the clinical practice when it comes to children? Can it be used as a screening symptoms? You know, how sensitive is that for us to kind of predict possibility of asymptomatic in any way kind of patients with positive COVID, especially talking about children?
Well, especially younger children, I think it's not much use at all. And I'm very glad to say I've not experienced COVID-19. I know that I lose my sense of smell whenever I get a cold. And I've always wondered, you know, it's clearly something different that happens, that people specifically say they've lost their sense of taste, lost their sense of smell. In children, you know, how subtly you can distinguish between what you experience when you get a cold and you lose your smell and don't feel very well, and the more profound loss that you get with COVID-19, I'm not sure. I think still, the majority of children are asymptomatic. You know, the high rates that we're seeing in the swabbing studies are on people that, as far as they're concerned, don't have symptoms. So we have to ask why we're trying to distinguish. Is it to work out, you know, who might be infected in a school setting, for example? It's no use, I would say. You know, that is just not use. You will have, the majority of children won't have any symptoms, and you're not achieving what you're wanting to achieve by excluding, you know, just using questions like that to work out who should or shouldn't be attending school. If we're talking about who's coming into hospital and wanting to isolate them, again, it's not sensitive enough. You need rapid COVID-19 testing to do this, and I don't think we can be using those clinical criteria in that setting. I don't have the exact figures for you, I'm afraid, in terms of, you know, the formal analysis of the sensitivity of asking lack of smell as a test. And I think that's a great question. You know, I'm not sure if that's been done or if that data are out there. Somebody might be able to tell me. But my gut feeling is strongly that actually nothing's going to be sensitive enough to use it how you might want to use it. And that we learnt the lesson, I think, during the first wave that testing just based on symptoms in children is not helpful in any context. You have to, if there's a setting where you want to definitely know if children have got an infection or not, you need to be routinely swabbing. Certainly that applies in hospital. We're not doing that in schools as yet. Maybe that will come along as tests become more available.
Thank you so much. That's very, very nice input. I think the reason why we asked this is during the first part when we wanted to reopen the hospital, I think people are very anxious, and we get this information about anosmia. And as a department, we try to apply this as part of screening, try to get an idea which type of patient possibly positive based on the ability for them to smell or the loss of smell.
Sure.
And we actually did some sort of a modification of the smell test, but fortunately or unfortunately, in a way you can see, we did not catch any of the patients turn out to be symptomatic or positive for the case. So at least on our side, we're not able to conclude what is our finding so far. But that was part of the initial stage where we try to screen our patient and try to use that information.
No, fair enough. I hope I haven't waded into a controversy there about different hospital policies and what was used or not.
Yes. Okay, so we have one question here. I think this is this is going to be one of the next question that I plan to ask. So this is from one of the audience. They say, what are your views on COVID-19 vaccination among children?
Yes, and thanks for that question. It's a great link to what I think is what a lot of people are interested in. So COVID-19 vaccination in children. As yet, the vaccine, as far as I'm aware, hasn't been, none of the vaccines that are being studied have been given to children, as far as I'm aware. I'm not as up with the situation in China and Russia, but in Europe and North America, that isn't the case. We, in our current, so I'm working here at the Oxford Vaccine Group. We are delivering the series of vaccines looking at the ChAdOx nCoV-19 vaccine. It's being developed within Oxford and now has support from AstraZeneca. We will have a paediatric arm of that study, which will be activated once we have effectiveness and safety data in adults. We do need to and will be looking at the immunogenicity and safety in children. We need that data. Now, a separate question, and I know that most of the companies have got a paediatric development plan for their vaccines. A separate question is whether we should be using it in children. And I think that relates to first we need to know if these vaccines interrupt transmission. I would say personally, clearly the groups that need to be immunized first are the elderly and healthcare workers. Children are right down the bottom of the list of groups that need immunization in terms of their direct benefit, protection against disease to them. This is not a priority. But if we were to find, with the emerging evidence, that actually children do spread the virus and are the transmitters within a major source of transmission within society, and this is a big unknown, if the vaccines interrupt transmission, stop the shedding, then there would be a case for immunizing children, definitely. We in our study are looking at, in adults, taking routine swabs, looking for asymptomatic infection in the immunized and control group. And so we will be able to tell whether the vaccine, the ChAdOx vaccine, reduces transmission of the virus, which is a big question. If we were to show that, and if it were to be seen that children do transmit the virus, then there would be a case for immunizing children, definitely. Much as we do with influenza at the moment. In the UK, we have a very big immunization campaign that goes up to early secondary school now. That's partly to protect the children, but it's mostly to protect their grandparents, because the children are great spreaders of influenza, and we might well be applying a similar principle to COVID if need be.
I think that's a very good input on that. I think we have a second question here from Chen Seong Jun. The question is that how risky will it be to allow children to attend school, and would possibly pose a risk to other households, especially those senior citizens?
Yes, that's right. So in terms of risk to the children themselves, that's minimal risk. I think we're clear on this. Minimal risk to the children. It's all about, will they be bringing the virus home to their grandparents or not? And that's the big question. It sounds strange, but we still don't know the answer to this. there is an awful lot of work that's been going on in England to try and address this. And I think there may be some data coming out from Public Health England shortly, looking at infected child going into the household and the number of subsequent infections that occur from that. Because that study hasn't really been done yet effectively. We can see that there are lots of infections in school, but that does not necessarily mean those infections are happening in, the transmissions are happening in school. It can be that the children are picking up the infection from their parents and then going to school. We don't know which way the transmission's going. We're so used to thinking of children as the transmitters for influenza, but that's not necessarily the case here. And so I think there are still data that are coming out regarding this. I've been, every Friday morning for quite some time, we were looking at designing the perfect study that would address this. And it's actually, to do this, to actually identify the order of transmission, you need up to 3 times a week sampling, for example, from saliva in children and their households to work out who's infecting who. It's not as simple as you might think.
Great.
And there is also the possibility, and I think just coming back to that data that we showed from Scotland, that living with young children protects you against COVID-19. I thought that was a lovely inversion of that question to say, actually, this might be the best thing you can do, get lots of exposure to children. It's a slightly reckless thing to say, I'm sure, but you know, we could be thinking about it in this way. Living with young children seem to be protective against COVID-19, possibly because of exposure to seasonal coronaviruses.
Saying that, I mean, you did mention about the seasonal coronavirus infections, the immunity that they build, the cross protection possibly protects against SARS-CoV infection. And you did mention that is a possibility why having children have that. I just wonder, do adults do not really have the cross protection by themselves? Do they not really,
When you look at antibody levels or seroprevalence, they're much higher in children than in adults against the seasonal coronaviruses. They do wane, yeah. And that's why the T-cell data showing some immunity in adults is interesting, and that seems to arrive from seasonal coronavirus exposure, and they have that perhaps it's more retained in the T-cells than in antibody levels. But definitely seasonal coronavirus infections are more common in children, and antibody levels are also more common in children.
Okay, I would like to basically ask you and move with this for the PIMS TS, or the multi-systemic inflammatory syndrome.
Yeah. Acronyms I can never remember the full names of, so we'll just call it PIMS TS. Yeah. MIS-C
and PIMS TS and Kawasaki-like syndrome, as people put it. Yes, you clearly actually discussed it and mentioned it. Just kind of to conclude it, where, or do you have any kind of idea or any kind of inkling to say who will be developing the case, who are possibly at risk? Is this patients, the cohort of patients unwell before? The data kind of like show that, but if I have a patient who are positive with SARS-CoV, in what kind of population I will be, more inclined or more worried to see the patient will develop?
It doesn't seem to correlate with severity. Many of these patients did not have any symptoms of COVID-19, of acute COVID-19. I'm trying to think, I don't think I've seen data broken down like that, looking at initial severity, because all we see, well, first we know about them is when they turn up to the ward and they're sick, and so we haven't had that longitudinal follow-up. But, retrospectively, the majority of them don't recall acute COVID-19 symptoms. And that does come down to which questions were they asked. Were they asked about gastrointestinal symptoms or respiratory symptoms or anosmia, and how was it asked, and so on. Anecdotally, and these data I'm showing here bear this out, that it was young teenage Black and Asian children, boys and girls, no difference for sexes. And we weren't sure initially if this was because it was the areas that were having highest rates of infection. London, Birmingham are also areas where there's a lot of Black and minority ethnic teenagers. But this formal analysis does seem to bear it out that that's the population. Why? We do not know why this seemed to be the case. I think it's really interesting. And again, the speculation was, it's because that they're living in more crowded households. This is a symptom of poverty or something else. That actually, in terms of the acute infections, doesn't seem to be the case. Whether or not it is with PIMS-TS, I have not seen data on. But the higher rates of infection in Black and minority ethnic of COVID-19 didn't seem to be related to socioeconomic deprivation.
Okay. Maybe one question on the vaccine. or before that, I possibly have a question from Professor Char with regards to the multi-inflammatory systemic, this so-called this MIS-C infection. For MIS-C, would you say that serology is crucial as a lab test, as the PCR may be negative in this post-infective condition, and which serology test is best?
Well, they're much more likely to be serologically positive than antibody positive than antigen positive. That's very clear, and does tie into the whole idea of this being a post-infective serology. All sorts of different tests are being used: nucleocapsid, spike protein, RBD. Really, in my experience of Public Health England, is we're seeing all those tests being applied, that there's no particular rigor being applied as to which test you should be using for specific conditions. We, in our seroprevalence study, are using both nucleocapsid and receptor binding domain. These are both has sensitivities and specificities to 90% for acute COVID, but I've not seen their performance tested against PIMTS, and that's a really good question that I haven't actually considered till now, and I don't have that data. I'm sorry. We do know that against acute COVID, some tests perform much better than others. Euroimmune, for example, is one test that has about 70% sensitivity, it would seem, so not quite as accurate as the Abbott test is one that was selected by Public Health England in their testing as one that was in their hands, performed very well, as did their in-house RBD, and I think they also used the Roche test in their hands. They thought they were the best performing for acute COVID. I don't have an answer about PIMS-TS.
Okay.
I guess that the same would apply, though, that if they were the most sensitive for having picked up previous COVID infections, they are the best tests for looking to see if a patient you've got in front of you has had a previous COVID infection.
Okay, there's an additional question from the thing. What are your thoughts about kids and pets with seasonal coronavirus cross protection?
Pets? Yeah, I don't have thoughts on that. I have a dog, and I like my dog. I don't have specific thoughts about. We have seen some cases. We have seen some transmission from pets, we have seen pets with infections, cats and I think dogs with infections. I think they are much lower risk overall than humans. I think being exposed to humans is much higher risk than being exposed to pets.
Possibly one last question, because we're at 6 p.m., but one last question, because I think this is just fresh of the thing. The mRNA vaccines, this is something relatively very new. No one actually using it. It's not yet clinically proved. I mean, it's not in the market. It's not even in the clinic proven yet. What is your opinion on that?
I think that, so exciting. I mean, we're thrilled. We're very involved here. We've enrolled 22,000 people to our studies of the ChAdOx vaccine. There was always an element of, genuinely is this a race or is this just a combined effort? And I think it really does feel more like a combined effort. We're absolutely thrilled with the data that's coming out for the RNA vaccines and their high effectiveness. Not just because that means there are at least some vaccines available, and thank goodness, it looks like they will be coming available as long as they pass their safety tests. Not just because of that, but also because they use the same antigen as us, the spike protein. And so that's really exciting that it seems like antibodies. We know that our vaccine generates antibodies and T cells against the spike protein. It looks like that's a good vaccine target. So we're thrilled from that point of view as well. We are hoping to have our data available before the end of the year in terms of effectiveness. And so lots of work going on, tidying everything up and getting it ready for that at the moment. The high number of cases that we're seeing in the UK is terrible news for the UK. But weirdly, it is good news for the vaccine development, because that means we're reaching our effectiveness endpoints more quickly, because we're able to look to see who's getting infected. Are there lower rates of infections amongst those who have been vaccinated versus those who've got the control vaccine?
Nice. There's a question. Why the mRNA approach in this vaccine development? Can you share some thoughts on this?
I think that is one of the most extraordinary things about all of this, is that it's the RNA was an experimental technology and has progressed so quickly. And likewise, the viral vector is, there are no only licensed vaccines for adenoviral vector vaccines are Ebola vaccines, which are also very new, and it's the newest technologies that have come through most quickly. RNA, it allows rapid scale-up. It's relatively cheap, and it allows rapid scale-up of production. And so I think there's strong advantages to those vaccines. It is interesting that it's a 2-dose schedule. You don't get such a good response to the first dose, but a very good response to the second dose of vaccine. And that is of relevance, obviously, when it comes programmatically. It is a little bit, the fact that the Pfizer vaccines needs -80 freezers will be relevant when it comes to implementation. It is reassuring that I gather that Moderna doesn't need such stringent temperature control, and it can be at 2 to 8 degrees for a short period of time. And I can say that the ChAdOx viral vectored vaccines is a vaccine that can be stored at 2 to 8 degrees, so it would be easier from that point of view. I've digressed slightly to a few random things about Vaccinology.
Great. I think we are at 3 minutes past 6 here in Malaysia. I would, before I end this, possibly I would like to invite the chairperson, Professor Dr. Chia, for any feedback or any comment. Again, Professor Fernandez, for any inputs or closing remarks.
Hi, thank you very much, Professor Matthew Snape. This is fantastic sharing of a very crucial, actually, a point in management of children in our country at the present state, because schools are all closed. Practically, children didn't actually attend school for the whole of this year. So I think there are a lot of concerns on this area, and you've shown us very important data. And if we need to convince our people on top there in terms of whether schools should be open or not, I think there's enough information there that we can share with them if it's necessary. You have actually talked a bit on the MIS-C. I think that's I actually prefer the word MIS-C than PIMTS. It's much easier, actually. I know the Americans tend to use MIS-C. I think the MIS-C is actually interesting, and we have actually seen, Adli, a few cases that may be MIS-C, and I think we were, basing a lot on the PCR, and I think we should have done the serology a bit more extensively.
Yeah, no, PCR wouldn't be relevant. It's just about the serology. Yeah.
Mm-hmm. And I think Adli has flashed the next sessions on the webinar series. I think the next one will be by Rin Song on tuberculosis, and in the new year will be Dr. Dominic Kelly on pneumococcal. And that'll be very interesting, actually, because we've just been told that Malaysia will be adding pneumococcal vaccination in our extended program of immunization, probably starting next year. So I think there'll be interesting information that we probably would gather from that talk, and to sort of ask the expert on what expectations and what to look out for when we start having our own vaccination program nationwide. So I think that's about all that I would like to say. Again, I want to thank you, Matthew, for that wonderful lecture, and to start the ball rolling. And George, is there anything you'd like to say? Thanks a lot again for putting all this together with us for the benefit of the faculty and the people over here. George, do you want to say some remarks?
There's really nothing to add than just to say thank you, Matthew. And this was, I think, a very exciting start to this mini-series, showing, again, how science can inform public health, the care of our children, and basically leading us into a COVID-free future. Thank you very much.
And to add to that, I must say it's one of the best presents that we will be getting, for all of us who are managing and treating children, that we're going to have much awaited and very important vaccination against pneumococcal in our national schedule. I think that's about all. And Adli, is there anything that you would like to say or for housekeeping for the next
As for housekeeping, we now come to an end of the session, I guess. And I would like to thank you everyone who joined us for today's webinar. Personally, thank you, Associate Professor Dr. Matthew Snape for an excellent talk. Professor Dr. Josh Hollander, thank you so much for being here. And yes, Professor Dr. Chia Cho and everyone for coming for this sharing a very insightful session. Just a bit on the housekeeping. I would like you to take about 60 seconds of your time to provide the feedback and register for your attendance for the CPD point. And for the medical students, I think there are 2 QR codes that you need to fill up. So yes, back to you, Prof. Chia.
So I think there's nothing really much to say. That is, I think we all agree that this fantastic session, and I really look forward for the next one. And I'm really glad for your attendance and your participation. It's even though it's a bit late in the evening for some. I really look forward to your participation for the next session. And thank you again, everybody, for attending. Thank you and good evening.
Thank you.
Thanks very much.
Bye-bye.
Okay, bye.
Bye.
Bye.